Hello, my name is Megan, and my integrative review was on medication-assisted treatment. The healthcare problem that this is about is the opioid epidemic, and this is something that is an enormous issue in the United States and across the whole world. Addiction is a primary, chronic, and relapsing brain disease and needs to be treated as such. Of the 20.5 million Americans 12 or older that had a substance use disorder in 2015, 2 million had a substance use disorder involving prescription pain relievers, and 591,000 have had a substance use disorder involving heroin. The importance of the problem is that drug overdose is the leading cause of accidental death in the United States. Opioid addiction is driving this, with 20,101 overdose deaths related to prescription pain relievers and 12,990 overdose deaths related to heroin in 2015. The overdose death rate in 2008 was nearly 4 times the 1999 rate. Sales of prescription pain relievers in 2010 were 4 times those in 1999. Substance use disorder treatment admission rates in 2009 was 6 times the 1999 rate, so this problem is continuously growing here. Addicts try to get sober every year, but are unsuccessful. This can be due to numerous different things, but mostly due to a lack of education on different treatment programs, lack of resources, and the lack of healthcare providers for treatment. One of the studies I reviewed was by Mokri et al. 2016. This was a randomized controlled trial to compare the effectiveness of oral naltrexone and sublingual buprenorphine naloxone. These are 2 of the 3 main medications used for medication-assisted treatment. They utilized a 12-week single-site, 2-group parallel randomized double-blind clinical trial. There was 102 participants that had opioid use disorder, and they were assigned randomly to naltrexone or to buprenorphine. Medications were administered 3 times per week, double-blind, double-dummy for the 12 weeks, with weekly group drug counseling. The primary outcome was initial duration of opioid abstinence verified by urine toxicology utilizing rapid test strips. Secondary outcomes included number of opioid-negative urine tests, treatment retention in proportions was sustained, verified opioid abstinence for 12 weeks. The mean number of days of initial duration of verified abstinence was found to be 28.8 with buprenorphine and 21.6 with naltrexone. The mean number of opioid-negative urine tests was 19.7 with buprenorphine and 15.4 with naltrexone. Mean number of days in treatment was 70.6 for buprenorphine versus 56.5 for naltrexone. Rate of sustained 12-week opioid abstinence was 16% for buprenorphine and 8% for the naltrexone group. Sublingual buprenorphine was associated with a greater number of opioid-negative urine tests and treatment retention than oral naltrexone, but not significantly greater at the initial abstinence duration or proportions with sustained abstinence. The second study I looked at was by Bazzari et al. Of 2016. This was a retrospective and naturalistic study to compare the impact of harm reduction treatment, HRT, and opiate agonist treatment, OAT, on patient outcomes as assessed through negativity for drugs on about 1-year urinalysis. They examined retrospectively the urinalysis of HRT and OAT patients for which at least 4 randomly sampled urinalysis per month were available for about 1 year, during which patients were undergoing methadone or buprenorphine maintenance. Methadone is the 3rd drug I was talking about in the present slide. Total of 247 participants, including 189 HRT and 58 OAT patients. Duration of abstinence was measured during urinalysis results using the enzyme multiplied immune technique. Duration or higher proportion of heroin clean urinalysis in OAT patients. Clean urinalysis percentages for OAT include buprenorphine at 97% and methadone at 93%. buprenorphine maintenance associated with more heroin-clean urinalysis. OAT approach related to higher recovery and polyabuse abstinence rates compared to the HRT approach, despite greater severity of substance use, psychiatric, and physical comorbidities. These results are consistent with the possibility to use lower maintenance opiate doses in treating heroin addiction. So to improve nursing practice, this is a great treatment option to treat patients struggling with addiction. It is important for us to know how to treat addiction and to have lasting positive outcomes. And this is to help as many people suffering with addiction as possible. As a psychiatric mental health nurse practitioner, we will have these type of patients and we need to know what is the best way to treat them. The proposed intervention would be medication-assisted treatment. So this is the use of a medication with counseling and behavioral therapies to treat substance use disorders and prevent opioid overdose. This has better outcomes than abstinence alone, and buprenorphine had best results on sobriety over methadone or naltrexone as evidenced through the studies. Healthcare environment that this would be great in would be the outpatient setting. This is the easiest way for patients to get the help they need and does not interfere with their day-to-day life. On top of that, there are professionals there to help with therapy and to help them find programs to afford the medication. In conclusion, medication-assisted treatment has better outcomes than abstinence alone. Thank you for listening, and I hope that you found out why this is better than just abstinence alone. Thank you.